Hey all, welcome back to the Real Life Pharmacology Podcast. I'm your host, pharmacist Eric Christensen. Thank you so much for listening today. Go check out reallifepharmacology.com. We've got a free 31-page PDF. It's on the top 200 drugs. I throw out some of the most important practice pearls as well as some of the most important things that are going to show up on pharmacology exams in your career as well. So definitely a no-brainer to have, whether you're in practice or whether you're a student going through pharmacology classes. It'll definitely help you prepare and become a better healthcare professional with a much better understanding of pharmacology. So again, simply an email will get you access to that at reallifepharmacology.com. All right, so today's episode, I am wrapping up kind of our series on cholesterol-lowering medications. I'm going to finish up with kind of some of the miscellaneous agents that are hanging out there that I haven't covered. Go check out previous podcast on statins. Also done PCSK9 inhibitors and ezetimibe as well, and fibrates as well. So again, I'm going to kind of cover a hodgepodge of medications here that lower cholesterol or are classified as cholesterol-lowering agents. And let's get into them now. So first one, bile acid sequestrants. Examples include cholestyramine, brand name Questran. Colestipol is another example in this class. These medications work in a unique way. They bind bile acid in the gut. When bile acids are bound and excreted, the liver actually pulls cholesterol from the blood to make more bile acids, which ultimately lowers cholesterol and lowers LDL. These drugs can lower that LDL in the neighborhood of 10 to 25%. Probably depends upon the dose and the drug here a little bit, of course, too. But they are a potential useful option in lowering LDL. I would say probably the biggest downside of these medications is we really don't have a lot of cardiovascular reduction supporting evidence. We can prove that we can lower cholesterol a little bit and LDL, but we don't have that supporting evidence from cardiovascular reduction side of things, or at least not as much as obviously some of the other agents like ezetimibe, for example. So that's kind of one small downside to these medications. But I would say the biggest thing that keep clinicians and patients potentially away from these meds, they do cause some GI discomfort for sure. So bloating, abdominal discomfort, and then constipation as well. And in fact, one of probably the main use I see a medication like cholestyramine used for is actually the treatment of chronic diarrhea, where we can't identify any other cause, and we're looking for a medication to help reduce that diarrhea. Constipating medications like the bile acid sequestrants, I do see periodically in geriatric patient populations. So again, that GI downside of these medications definitely keep clinicians and patients away from them. And then the other thing is binding interactions. So if we take these medications close to many, many other medications in timing with oral administration, we're going to potentially block the absorption of other medications. And in our geriatric patient population, in our polypharmacy patient population, that's a huge deal. And so, again, another reason why you really don't see these medications used terribly often for their cholesterol-lowering effects when we've got, generally numerous other agents that we're going to go to first. All right, so next drug I want to talk about is niacin, or vitamin B3. Definitely saw a lot more niacin when I first, graduated, 15 plus years ago now. I don't see it very often anymore. Okay, so niacin can lower LDL a little bit, also can work on lowering triglycerides. potentially can raise HDL a little bit. When HDL was kind of all the rage and getting HDL levels up and stuff, that's probably when I saw a little bit more niacin being utilized. It actually works by decreasing the liver's production of VLDL, which ultimately reduces LDL levels there. So it has fallen out of favor, particularly because of its adverse effect profile. As we escalate dosages and increase those dosages to where we actually lower cholesterol, it can cause significant GI symptoms, as well as the common test question of flushing. So you can get this redness in the face, flushed face type reaction with this medication. So I've definitely seen that come up a bunch as far as kind of a supplement, over-the-counter niacin type adverse effect. It can cause flushing. Rarely has been associated with liver toxicity as well. From a dosage formulation standpoint, the extended release formulations may help reduce that flushing activity or that adverse effect, but the liver potential issue does still exist. Again, very, very rare. I don't think I've ever seen a case in practice that I recall that niacin itself just caused liver toxicity, at least in kind of usual standard dosages. So again, might be an option in patients with kind of mixed dyslipidemia, very low HDL, but again, in clinical practice, we're typically focused on LDL and those agents that lower that. All right, let's take a quick break from our sponsor, and we'll wrap up with the other two medications. If you're in the market for any pharmacist board certification study material like BCPS, ambulatory care, BCMTMS, geriatrics, or the NAPLEX exam, we've helped thousands of pharmacists pass their exam at meded101.com/store. You can find all the resources and links to those study materials. In addition, if you're a nurse, pharmacy technician, med student, any other healthcare professionals that need pharmacology education, we've got tons of resources out there. Books on drug-food interactions, crossword puzzle books, review courses, all sorts of different stuff that can absolutely help prepare you for practice, as well as pharmacology and board exams as well. So again, help support this podcast, support the sponsor, meded101.com/store. All right, so moving on to omega-3 fatty acids, I would also kind of loop in fish oil here as well. These primarily target triglycerides. Again, usually the go-to medication for lowering triglycerides is going to be those fibrates, which I talked about in a previous podcast. So go check that out if you want more info on that. But omega-3 fatty acids, they can help to lower those triglycerides. Doesn't really affect LDL near as much as the triglyceride risk there. So high triglycerides, what's the issue with that? So if they're very, very high, we can run into pancreatitis and maybe a little bit more of a risk factor for cardiovascular events as well. Cardiovascular events, typically we're going to focus on LDL being our primary target versus triglycerides. But kind of depends upon the situation and how elevated those triglycerides are as well. Now, with omega-3 fatty acids, we do have prescription formulations. The most notable one I'm going to say is icosapent ethyl. So this is a type of product that has strong evidence for cardiovascular risk reduction in high-risk patients with elevated triglycerides despite statin therapy. Okay, so patients where maybe that LDL has come down with statin therapy, but their triglycerides are significantly elevated. So in that situation, icosapent ethyl might be a potential option there, because we actually have some clinical evidence, some trial evidence to show that we were able to reduce cardiovascular risk in that situation. Dosing of various products, 2 grams twice a day with meals. Omega-3 fatty acids over the counter are generally, pretty well tolerated. Obviously, we don't have the evidence to support some of those products because, not all of them have been individually studied. So that can certainly be a challenge there as well. With particularly some of the over-the-counter products, categorized as fish oil type products, they can have a fishy aftertaste with capsules and things like that. Also can cause some mild GI upset, and rarely, it's been reported that there may be some issues with bleeding and interference of platelet action and things like that. So generally, I'm not crazy concerned about that clinically, but if I have a patient that's, consistently reporting that they're bleeding or bruising or, have a low hemoglobin or something to that effect, if they're taking a fish oil supplement, that might be something that, I at least consider and look at and say, hey, is this fish oil doing anything? Are they taking it for a purpose? Or, did their neighbor just tell them to start taking it? So, again, not crazy high on the bleed risk with fish oil, in my opinion, in my experience. But it is something to be aware of, particularly if you have a patient that's having a little bit of trouble there. All right, now the last medication I will cover is bempedoic acid. I have done a full podcast on this medication, so I'll just really hit the highlights here. But if you want the full rundown with lots of drug interactions and more details on dosing and all that stuff, go look it up on the Real Life Pharmacology website, and you'll find that podcast there. But this is a relatively newer oral cholesterol lowering medication. It works a little bit upstream from statins, and it actually inhibits ATP citrate lyase in the liver, and that lowers or reduces cholesterol synthesis. It is activated in the liver and not as much in that muscle tissue. So in patients who have that statin-associated myopathy and muscle-type adverse effects, bempedoic acid is likely to have less of that risk than the statin medications. Now, on the LDL lowering side, it's not as potent as statins. So it's going to be similar to ezetimibe, probably in the neighborhood of 10, maybe up to 25% when used alone. Obviously, if we combine it with other agents like ezetimibe, we can obviously get kind of additive reduction there, and maybe up to 30 to 50% when those two medications are used together. So other thing with that said, probably where I've seen this medication a couple of times, haven't seen it a ton because it is expensive, is where we've got a patient that absolutely cannot tolerate statins and or won't take statins. And maybe they don't want the injection with PCSK9, or they can't afford it, or insurance is a problem or something. Bempedoic acid could possibly be used with ezetimibe to try to get you some additional LDL lowering effects there. So again, much more expensive than ezetimibe, and we do have quite a bit of clinical evidence with the ezetimibe as well, and experience obviously with its use there. So when people need more LDL lowering after statins, we're typically going to add ezetimibe before we'd ever get to bempedoic acid. Adverse effect profile with this medication. Big one to remember, probably the one you're most likely to get tested on, is uric acid levels. It can raise them, okay? And if you remember, uric acid plays a really, really important role in gout. The higher the uric acid levels get, the more and more likely that you're going to have issues with gout or gout flares. So pay attention to that in patients for sure. Rare, mild increases in liver enzymes have been reported there as well. All right, so that's going to wrap up the podcast for today. Do me a huge favor, leave a rating, review on iTunes or wherever you're listening if you found this podcast beneficial. I greatly appreciate that. Of course, support the sponsor, meded101.com/store. All your purchases there go to directly support this podcast. So I greatly appreciate that. For those of you who have, purchased a review course or a book or whatever the case may be, I greatly appreciate that for sure. If you have any comments, questions, suggestions, feel like I got something wrong, I'm definitely not perfect on these. I do my best. mededucation101@gmail.com. You can track me down there, shoot me an email. That's probably the best way. If you can't track me down there, or maybe I missed it, it went to spam or junk or something, or whatever the case may be, you can connect with me on LinkedIn as well, Eric Christensen, PharmD, BCPS, BCGP. All right, I'm going to sign off for today. Thank you so much for listening. Take care and have a great rest of your day.